Hi, good afternoon, everyone, and thank you so much for joining our event where Dr. Somner will be diving deeper into the benefits of SPECT imaging. And before we fully begin, we would like to each share a little bit about ourselves. So my name is Kathleen Anoa, and I work for the Amen Clinics as the East Coast Clinic Outreach Manager. My role is to help spread the Amen Clinic message to other professionals in the field. And for those of you watching that maybe aren't too familiar with our clinics, Amen Clinics is one of the leaders in using brain imagery to help treat emotional issues, behavioral challenges, cognitive problems, and learning challenges. The brain imagery captures areas of the brain that are either working well, are working too hard, or they aren't working hard enough. And our founder, Dr. Daniel Amen, he's been using SPECT scans for over 30 years, which has created a database of about 180,000 scans. And our doctors use the research developed through this database to assess our patients using a brain systems lens and treat our patients holistically. Psychiatry is shockingly the only medical field that doesn't look at the organ that we're treating, and we're really trying to change that at our clinics by just finding the root cause of our patients presenting problems rather than just treating them using a list of symptoms that they report. Our mantra really is, how do you know unless you look, right? So Maria, would you like to introduce yourself and the amazing Dr. Somner, who will be talking even more about SPECT?
Good afternoon, and thank you for joining us today. My name is Maria Luby. I'm the Clinic Outreach Manager for the Washington, D.C. Clinic in Reston, Virginia, and I am proud to introduce our presenter today, Dr. Lillian Somner. She is one of the psychiatrists that's on staff at the Washington, D.C. Clinic. I'm going to talk about her biography, and we're going to have a little clip that's going to show her personality quite a bit. And then we'll get started on the presentation. So Dr. Somner graduated from Maryland University with a degree in modern dance. She has always understood the relationship between the body and the mind. She attended the New York College of Osteopathic Medicine, did a rotating internship covering all the specialties, and went into private practice specializing in osteopathic manual medicine. She then added medical acupuncture and is board certified in medical acupuncture by the American Academy of Medical Acupuncture, which is an organization devoted to teaching physicians. She did her residency in psychiatry at the University of Medicine and Dentistry in New Jersey, where she was chief resident. In addition to her residency, she also completed training in psychodynamic psychotherapy in Philadelphia at the Philadelphia Psychoanalytic Institute. She is board certified in psychiatry. She is also board certified in metabolic medicine, perspective of looking at of why something is wrong, not just that something is wrong. This training allows a deeper understanding of both the physical and mental illnesses. Dr. Somner was the medical director of behavioral health at Twin County Regional Hospital in a very rural area of southwestern Virginia. She is acutely aware of the needs of rural communities and has a great deal of experience in the management of many disorders, including schizophrenia, bipolar disorder, attention deficit disorder, and depression. Dr. Somner has been in practice since 1990. Her specialty has been in the management of pain, utilizing both manual techniques and acupuncture. She incorporates her thinking and understanding of the body-mind connection and the underlying metabolic problems that may be contributing to these issues. She's also been trained in the Bredesen protocol, which is an approach to stop the decline of Alzheimer's dementia and its possible reversal. The training dovetails perfectly with Dr. Amen's memory rescue, bright minds approach to the improvement of cognitive impairment. So I would like for you to see a little clip of Dr. Somner. This is why she works at the Amen Clinic, and then we'll get started with the presentation. Thank you so much for joining us today.
I work at the Amen Clinics because it's a lot of fun to take the scans, connect the dots between the scan and the patient's symptoms, utilize all of the functional medicine tools, lifestyle, diet, exercise, supplements, nutrition, medication if needed, put all of that together into a plan that they can implement, and I get to watch them get better. Maria, thank you so much for that great introduction. And thank you to all of you who are listening in this afternoon. I appreciate you taking some time out of your busy day to listen to me talk a little bit about SPECT scans. What we're going to do this afternoon is a clinical introduction to the SPECT scans and how we use them in psychiatry. And as Maria said, I'm Dr. Lillian Somner. I'm one of the psychiatrists at the Amen Clinic in Reston, Virginia. So what I'll cover this afternoon is a brief explanation of how the scans are made. I'll show you a slide on that. An explanation of how to interpret the scans clinically. So I'll give you a crash course in how you can do it on your own. And then I'll give you several examples of how the scan findings actually inform the treatment options, and then I'll give you a summary and conclusions. So how are the scans made? So scans, these scans are SPECT scans. They're single photon emission computerized tomography, which is this fancy wording here. So what this gives you are slices of the brain, just like any CT picture would be. And I think Dr. Amen's great, brilliant stroke of brilliance was to take all of those individual slices and put them together into a three-dimensional picture. So what we see actually looks like a brain and people can relate to it. So the way these are made is the tracer material goes into the bloodstream and it attaches to the red blood cell. And it goes wherever blood is flowing. So when there's an area where the brain is active, it'll pick up the tracer material and it'll pick up the color. If the brain is underactive, you'll have some decrease in that color, and so it'll show up as a deficit or as a whole. If the scans are if the brain is overly working, then the brain will pick up a lot of tracer material, and that's how we make sense out of it all. So how does this compare to an MRI or an fMRI or a CT? So the SPECT is something that shows you how something is functioning, what the blood flow is like. If you take an MRI, it's like taking a photograph of your house. So you can see the structure, but you can't tell if anything is working. You can't tell if the electric is flowing or if the water is on. But in the SPECT scan and in the fMRI and the PET scans, you actually see blood flow. The problem with the fMRI and the PET scan is that they're very expensive and they're extremely limited in their use and usually for research purposes. So again, the CT shows just a static picture, the MRI just shows a static picture, but the SPECT gives us the opportunity to see how the brain is actually functioning. So here's a couple of examples. This is the surface of the brain, and these are the deeper structures of the brain. These are examples of healthy scans. So let me just orient you so that this is the beginning of your crash course. So here on this left-hand side is the surface, pictures of the surface of the brain, and the colors aren't meaningful. Here in the deeper structures, the colors are meaningful, and I'll explain in a second. So here is the brain from the top, if you're looking down from above. This is the front, the back, the right, and the left. If you take that brain and you flip it over and you look at its undersurface, like you're looking up from your feet, that's what you see in this upper left-hand corner. This is the front, the back, the right, the left, the brain from the right, and then the brain from the left. Now this view is the deeper structures, and here the colors are meaningful, but the views are the same. So this is still from the top, the front, the back, the right, the left. You flip it over, you look at the bottom, front, back, right, left, brain from the right, brain from the left. Now in these deeper structures, the colors are meaningful. So blue is the normal blood flow activity of the brain. So when the brain is just normally working, it picks up the tracer material and turns it blue. When there's more activity, it'll turn it red. And when it's extremely active, it will turn it white. So the most active part of the brain is the cerebellum, and you should have white and red all the way around, all the way across here, which we do in this case. And then I'll go through these other structures in just a moment. So what we're looking at is what's working not enough, and what's working too much. So the surface scans is where we really see what's working not enough. And again, the tracer material gets picked up, but if that lobe is turned down and its activity isn't up to snuff, then it won't pick up the material and it'll show up as a deficit or as a whole. And I have some pictures to show you of that. So here are examples of areas of the brain that are not working enough. So if you remember from the moment I just showed you, a moment ago, I showed you some healthy looking brains. So there were no big holes anywhere. So in this particular individual, the prefrontal cortex here isn't working enough. It's not picking up that tracer material. And so we're seeing a deficit. And we have a little bit of a deficit on the dorsal surface as well in this particular individual. In this individual, you see a very significant amount of decrease in blood flow here. So it's not like the blood flow has been reduced because the blood vessels aren't getting the blood there. It's because that lobe isn't working adequately, and so it's not picking up that tracer material. And you can see that this person is having some difficulty, and you would expect this person to have some symptoms based on what that prefrontal cortex is doing, what its job is. So what else are we looking for? So in these deeper structures, we're looking at areas of the brain that are overworking. So where is that brain working too hard, as Dr. Amen calls it? Where is it a busy brain? So as I said before, this back part of the brain is the cerebellum. It's the most active part of the brain. It should be on fire, and in this particular individual, it is. In this individual, back office isn't doing so hot. This cerebellum is really not as active as we would like it to be, and it's not as active as it is in this particular individual. What this individual has, though, is a lot of activity throughout the whole rest of the brain, compared to this one, which is a little bit quieter. And this one has a lot of overactivity in this limbic system, in the basal ganglia here, in the anterior cingulate here. Here, these are a little bit quieter. So this particular individual is going to have some symptoms of overactivity of the brain. So what are some of these regions that I've been talking about? So in this example, we have a big picture with a big yellow arrow, and that's pointing to that prefrontal cortex. And this is the part, the prefrontal cortex, as I've just shown you, is three-dimensional. But this is the part that sits on the top of the eyeballs. And this is an area where there's a significant decrease in blood flow in this particular individual, as you can see, because of these large deficits. Now, the prefrontal cortex, this is your crash course in what all of this means. So the prefrontal cortex is associated with focus, concentration, organization, planning, motivation, executive decision-making. All of those important executive thoughts and decisions all happen here in this prefrontal. And you can see in this particular individual that this particular individual also has this indentation here at the top of the brain. So this individual is going to have some trouble with all of these issues, all of these activities of that particular lobe. They're going to be harder or not present. And this is where you get a classic attention deficit. And then the white arrow shows the temporal lobes. And the temporal lobes in this individual are not in terrible shape. You can see them pretty clearly. They're nice and round. You can see them fairly distinctly. They're maybe a little smaller than they might be. But the temporal lobes are responsible for memory. So when people have problems with their short-term memory, very often we see that the temporal lobes are not adequately functioning, and we see that on the scans. So memory and everything to do with language, word finding, verbal expression,
reading comprehension, all of those kinds of things, auditory processing, all of those kinds of things are processed through the temporal lobes. But you can also get some mood lability. This bottom part here, where you've got the red arrow, this is the cerebellum. The cerebellum's job is to organize complexity. It's what allows you to organize your musculature to be able to play a sport or do a dance routine. It also is what I call the back office, because it helps that prefrontal cortex do its thing and its focus and its concentration and its executive decision making. Now here in this yellow arrow, we show you the dorsal surface. So this is, again, the prefrontal is three-dimensional. And you see in this yellow area, yellow arrow shows you a decrease in blood flow here. So this individual is going to have trouble, again, in that prefrontal cortex, all of those executive decision making. This is also called the longitudinal fissure. Longitudinal because it goes from front to back, and a fissure because it's an indentation. So that should not be present in the healthy brain, and a lot of times when we see that, we're beginning to see some cerebral atrophy and maybe some memory issues. Where we see the white arrow is showing a lot of bumpiness in the parietal lobes. The parietal lobes are the GPS system of the brain. They're what allow you to navigate where you're going. They help you read a map. They help you have a spatial relationship or awareness so that when you look at a parking spot, you can say, yeah, it's big enough for my car can fit there. This is an area where we can also pick up the possibility of exposure to toxins. Has there been drug abuse? Is there Lyme disease? Are there viruses? Are there heavy metals going on when the parietal lobes are bumpy or scalloped, as the scan readers will sometimes call them? This is also an area that's associated with reading comprehension. And when you have some scalloping here, you can also have some sensitivity to light or to sound or even to textures. Now in this bottom area, this area here, this red arrow is pointing to a small hole here in the back. Now this is not the cerebellum, but it's the occipital lobe, and this particular individual may have had some kind of physical injury that caused a decrease in function of the occipital lobe. But the occipital lobe is associated with vision. That's where you get your vision from, is the occipital lobe, and also visual learning and the ability to visualize. So it's a common place for physical trauma. Okay, now we've moved from the surface and we're going now into the deeper structures of the brain, and I'm going to give you a crash course on how to interpret that. So I'm going to start in the back of the brain and come forward. So again, in these particular scans, the blue is the normal level of function and blood flow. So red is more and white is most. So where you should have the most activity is where the brain is very, very active. So the cerebellum is an extremely active area of the brain. It is red all the way across. This individual has some white in one side, but it's not white all the way across, which we would expect in a normal cerebellum. So I call it the back office because its job is to organize the complexity and to help support that prefrontal cortex in doing its very busy job of executive decision-making, focus, and concentration. But the other things that are relevant in this particular picture, I'm going to talk about as one whole piece, and then I'll break them down into individual parts. So what you have here is what we call a diamond. And it looks like there might even be a diamond plus here. So what you have here is a diamond shape. And when every single one of these structures is overly active like this, it's often associated with emotional trauma or post-traumatic stress disorder. Now, this doesn't give you the diagnosis of PTSD, but it would support it. If there are symptoms of PTSD, this finding would say, yeah, this is probably, that's probably a correct diagnosis. So let me break these down. I've already talked about this one. So let's talk about the white line. The white line is an overly active thalamus or limbic system. This is an area that's associated with mood, with depression. You can see mood cycling here. When there's a white center with a red circle around it, sometimes you'll have cycling. Doesn't mean bipolar necessarily, although bipolar disorder can show up here. But it can mean cycling, such as moodiness with the premenstrual cycle, or moodiness with the change of seasons, or just moodiness within the course of a day, of a given day. And when it's very hot like this, the chances are that you have some fairly deep depression, and maybe even in spite of medication. So with this blue arrow, this is an area of, and this is called the basal ganglia, and the basal ganglia are associated with anxiety. So when someone has a white center in each one of their basal ganglia, this is a very overly active basal ganglia, and they tend to have a lot of anxiety. This particular individual might be extremely anxious. Also, what happens here in the basal ganglia is you get the feeling of things aren't going to work out for me. The worst case scenario is always the one that is going to happen to me. A lot of negative self-talk, both subconscious and conscious, happens here in this basal ganglia. And then this red arrow that shows here, this is the anterior cingulate. This area is, I guess I call it orange. This area here is the anterior cingulate, and it is associated with being stubborn. So you have difficulty shifting gears and going from one thing to the next. And so if something isn't going your way, it's a little difficult to go ahead with it and to move forward. This is also where you can get stuck on things. So if there's an anxious thought or an anxious worry or a particular fear, this can keep it around, so it's more difficult to let things just roll off your back. This is where you can get some ruminations. So all of those worries can stick around and they can actually rise to the level of rumination. That's where we see our OCD, where we get the OCD. And when all of this is together, we see the PTSD, because the PTSD is where all of those feelings keep coming back in the form of flashbacks and nightmares and things that are carried with you. So this is my first example. This is Mr. JC. Mr. JC is a patient that I saw recently. He's 61 years of age. And when I have an evaluation to do, I look at the scans first. And so this is what I saw. And based on the description of all of the different areas in the lobes and what they do and what they mean, we can kind of guess what kind of problems he's likely to have. So here, this is his surface scan. Again, the colors aren't meaningful, but this is the brain from the top looking down from above, the front, the back, the right, the left. You take that brain and you flip it over and you look at the undersurface, and that's what you have here. You have the front, back, right, left, brain from the right, and then the brain from the left. Now you can see from all of the holes and the deficits that he has significant decrease in function of almost all of these lobes. So this prefrontal cortex is badly damaged. When you look for the temporal lobes, it's hard to find them. They're almost missing in this scan altogether. And when you look at it from the side, you can see very clearly the problems in the parietal lobes as well. And you may even see some occipital lobe. So one of the first things that goes through my mind is, did this person have a serious injury? Is this a problem with some kind of physical trauma that has happened? My second thought always is drug abuse. You know, is this somebody who has had very long-standing and serious drug abuse? Or is there some other underlying catastrophic metabolic problem? Those would be the three big things that would be on my mind to look for in the history. And then if we go down into the deeper structures of his brain, and again, this is the brain from the top. If you're looking down from above, the front, the back, the right, and the left, you flip it over, and that's what you see here. Front, back, right, left, brain from the right, and then the brain from the left. And of course, again, the blue is the normal level of blood flow. And you can see that his cerebellum is smaller than it maybe should be, but it's not in bad shape. He's got light all the way across. So he at least has some back office function. This limbic system is a little bit overly active, and you see a little bit of basal ganglia action here. So he maybe has some depression or some moodiness and maybe a little anxiety. Now, I wouldn't be surprised at that because of what's going on the surface. If he has all that difficulty with thinking, I would imagine that he might feel anxious or that he might feel some depression, especially since this prefrontal cortex looks like it can barely function. So he's going to have a lot of trouble with executive functioning. And this is also an area where you have relationships with other people. This is where your empathy comes from, is this prefrontal. So this is his history. He has had a gradual decline in memory over the last 10 years. Now, we're not surprised to see that because he has very little in way of temporal lobe function, which is where the memory is located. He had multiple head injuries while playing sports in high school and in college with at least one loss of consciousness. So when you have multiple head injuries, they build up on each other. So you don't have to have one big one. You could have one and then another one and then another one. And this is why so many of the football players at the end of their career have trouble remembering anything and have a lot of difficulty. In addition to that, he had open heart surgery to repair an aortic aneurysm back in 2014. He at that time was diagnosed with Kawasaki disease. Now, Kawasaki disease is significant in an adult because it's a disease of vasculitis of medium-sized blood vessels, and usually patients do not live past the age of 5 years. Now, he didn't know that he had Kawasaki disease, so it's very unusual for someone to reach adulthood without that knowledge. And one of the things that Kawasaki does is it inflames the blood vessels, and it specifically encourages the development of aneurysms. And those aneurysms very often happen in the carotid arteries, but usually in children. Now children are being diagnosed early and they're being given IV intravenous immunoglobulin and they're surviving to adulthood. But in this particular unusual case, he managed to survive to adulthood until he had the aortic aneurysm. But I think there's a component of vasculitis, most likely, that's going on in his brain as well as in the rest of his body. He was also diagnosed with lead toxicity and is undergoing active detoxification. So when you have lead toxicity, all of the heavy metals just land right into the blood vessels. And they often cause hypertension and vascular disease of any kind. And so this unfortunate individual has multiple head injuries, Kawasaki vasculitis, which is a genetically inherited problem that leads to an inflammatory condition of the blood vessels, as well as lead toxicity. So he has multiple problems. And his geriatric psychiatrist diagnosed him correctly with frontotemporal dementia. So if we go back for just one moment, he has a frontal lobe problem and a temporal lobe problem, and where there's very little blood flow and function in either of those lobes. And so it's a most unfortunate diagnosis, especially in such a young person of 61 years of age. So the treatment focus that I did with this particular individual is to just increase the nutritional and blood flow function of the brain as much as possible. So I would encourage him to continue with the heavy metal detoxification. You want to try and repair the damage that's been done to the blood vessels by using the hyperbaric oxygen therapy, as well as Dr. Amen's supplementation of the brain and memory power boost, some omega-3s, some other things as well. But I also really wanted to work with his wife, because his wife was getting very frustrated with him because he couldn't function. And she was getting angry at him because he couldn't function. He can't process what she's talking to him about. And for good reason. He has very little of the temporal lobe to be able to process the auditory information he's receiving from her. And then he wasn't able to connect with her either because of that prefrontal damage. So the focus is really on poor prognosis, and how can she take care of him for long-term care, and how can she best support him and herself? How is she going to get some support for herself too, to watch somebody she loves and has been married to for many years go through something as devastating as this? So this is another interesting case. This is Ms. KP. She's 58 years old. And this is, again, her scans. This is the surface scan. The brain from the top, the front, the back, the right, the left. You flip it over, look at the bottom surface. Front, back, right, left. Brain from the right and brain from the left. Now you guys are going to be saying that in your sleep and hearing my voice. All right, so again, the colors are not meaningful, and her brain is not in terrible shape. She has a little bit of trouble, maybe in this prefrontal cortex isn't quite as full and juicy as it might be, but it certainly has no holes, no big deficits. Her temporal lobes are maybe a little smaller than they should be, in that you can see a little more space here than you might. But again, you can see them clearly. You can see a nice round temporal lobe. They're functioning fairly well. She has a little bit of deficit here in the dorsal part of the frontal lobe. So she maybe has a little bit of prefrontal cortex problems. And her parietal lobes are not in terrible shape. They're not super bumpy. They're not in bad shape. We're not concerned about toxicity with her. She might have like minor troubles, but nothing really awful on this surface. Now, when you come here and you look at her deeper structures, if you look at the active scans, on this bottom right-hand side, again, this is the top, front, back, right, left. Flip it over, front, back, right, left, from the right, from the left. So the first thing you notice is that her cerebellum is very low in activity. So she's not going to have the back office activity that she needs to help with that prefrontal cortex function. So she might have a little bit of ADD. But again, not terrible. And the cerebellum is treated oftentimes with interactive metronome, which is a very effective occupational therapy tool to help turn on that cerebellum. Physical activity that crosses the body, like some kind of sport that is a racket sport, like tennis. I know one of Dr. Amen's favorites is table tennis, because it gets you across the body. And then if you take a look at this, she has a lot of activity in her emotional centers. So this area here is the deep limbic system. It's where you have your deep emotional center. And she has some white right here in the middle and some red all around. Now, this area implies that she may have some moodiness or some depression. And then if you look at the basal ganglia here, the basal ganglia are pretty hot with white centers in both of these basal ganglia. So I would expect her to have quite a bit of anxiety. Some mood, some anxiety, and maybe a touch of attention deficit. But it really, again, just a touch. So this is her history. Her reason for coming into the clinic was her primary complaint is lifelong insomnia. So her insomnia started when she was 6 years of age. And she also wanted to know if she had any evidence of a prior TIA. Now, TIA stands for Transient Ischemic Attack. And the definition of a transient ischemic attack is, in fact, that it's transient. So ischemia means that there's a decrease in blood flow to the region, and it doesn't leave its mark. It doesn't kill anything off. So you can have a decrease in blood flow, but you're not going to have damage to the tissues. Nothing has been deprived of oxygen and blood flow long enough for the tissues to die. So you're not going to see that with her, because she of course doesn't have any evidence of cell death. She was diagnosed with ADD, and she's currently taking Vyvanse, so you can see how she might have a touch of it. But her sexual abuse started when she was 6. Well, what else started when she was 6? Her lifelong insomnia. This lady is on high alert. She's on high alert all the time. And currently, her son is having significant mental problems, and she feels like she has to constantly be on the alert to be there for him. So she has no capacity to stop. She has no capacity to relax. Her body and her brain are on high alert from the age of 6 on up to now. And she doesn't want to let go because of her son. So my treatment focus with her was easy things first. There's no TIA. I already explained that. But from my perspective, her insomnia is the result of her untreated PTSD. She feels like she can never drop her guard. She's on high alert all the time, and not only for her, but also for her son. So she has no motivation to be able to try and make herself feel safe. And I had suggested to her that she try and make her room safer for herself. And sometimes that means putting an extra lock on the door. And she was unwilling to do that because of her son. She wanted to be able to have him have access to her if he needed her. Now, this is an adult son. There's a mild decrease in blood flow to the prefrontal, so I don't really see that Vyvanse is necessarily the best choice for somebody who's on high alert like this. Her nervous system is already going like this. So I can see why she might have some trouble, but I would go more with something like Focus and Energy Optimizer to help her with her focus because it's so mild. But also I wouldn't want to give a stimulant and increase the dopamine to somebody who is already whose sympathetic nervous system is already pumping out everything. So my focus with her was to encourage her to relax to the best of her ability, whatever she would be able to do, even if she could find some time where she was alone, where she just took 5 minutes to take a time out. This is an interesting case too, because this Ms. JR is 62 years old. This is a classic ADD brain scan. So when you look at this prefrontal cortex, you can see that you have a decrease in blood flow all throughout this prefrontal, and the temporal lobes are low as well. Now, I have noticed just from working that when the temporal lobes are low, they will perk back up when you start to treat this prefrontal cortex. So when the prefrontal is stimulated, the temporal lobes will often just perk right up as well. But she has had a hard time keeping a job her entire life because she couldn't stay on task. She couldn't complete anything. She couldn't stay on the topic. And when I first met her, it was hard to have a conversation with her because she was going and jumping from this and that. And, you know, goodness gracious, I was always pulling her back to, all right, let's finish this topic before we go on to the next topic. So what I did with her is I added just a small amount of Adderall, 10 milligrams was enough. And she was so excited because she came back and she was able to complete a task. She said, I can finish something. She was really excited about it. But it increased a little bit of anxiety for her. And one of the things that we do at the Amen Clinic a lot is we use Lamictal, which is a mood stabilizer. It's a seizure medication. And it helps that basal ganglia be a little quieter, and it gives some stability and a floor to the brain so it can tolerate the stimulation, which is what I did with her. And once she got up to 100 milligrams, she was a very happy lady. I think she'll need a little bit more Adderall. We just bumped it to 15, and we'll see how she does. She may also need a tiny little bit more of Lamictal, but she's off to the races. She's done really, really well. She's been trying for a long time to get a business started, and now she feels like, maybe I can actually get it started, and she's actually done some work on it. It's just sad to me that she has had to wait all of this time before she finally got diagnosed with ADD and had her ADD treated. So in summary, just to pull everything together, I've explained how the scans are made with the IV tracer material. I've explained how the tracer material allows us to see where the brain is underworking, where it's overworking. And I've also given you some examples of, I've given you 3 cases of where the scans actually determine the treatment approach. So I want to thank you all for your attention, and I am open to questions. So thank you so very much for all of your time.
Dr. Somner, thank you so much for your valuable walkthrough. This was so informative, and thank you all for being here with us. So this was so fascinating to see a brain systems view of the regions and understand more about SPEC through functional imaging. And we are going to open things up for questions that many of you have. Warmest greetings. I am Donna Lawani, and I work in clinical outreach. We have a team of 9 national clinics and clinical outreach managers. So for those of you that may also be interested in seeing the clinic through an in-person visit or tour or a virtual tour, we are honored to follow up. For those of you, feel free to chat in your questions at this time. We'll be picking a few of them up. I thought the highlight cases that you had shared, Dr. Somner, were really quite fascinating. A great reminder as well for the value of looking deeper at some of the 11 major risk factors, that Bright Minds approach, and supportive care, not just for brain healthy aging. The Memory Rescue Program is so powerful as a comprehensive program, but in general for brain optimization, early identification of issues and concerns. So I thank you for bringing that information to light here today. And there are a few questions that I'm seeing coming in here about the application for different cases, how we would be using SPECT. So someone had a question about Asperger's. Would it be helpful for folks to have a scan? What are your thoughts, Dr. Somner?
So Asperger's is part of an autism spectrum, which we don't see on the scan in a place. Autism presents itself in such a wide variety of ways that there's not a classic scan finding. What you do to treat and diagnose and treat is really through history and neuropsychological testing. And then you just treat whatever you see in the scan, but there's not a spot. It's not like you can have a classic ADD finding. You don't have that with Asperger's. That's a little trickier.
But we do see, and I think a couple of people had asked questions about applications for different subtypes of anxiety, depression, addictions, PTSD. Someone had a question as well about concussion and TBI, of course. Some of the findings you had shared about dementia and Alzheimer's, bipolar and schizophrenia, just to name a few. One individual asked particularly about some of the recommendations and thoughts for depression. And what are your thoughts on hormones? looking at and identifying and treating with hormones?
Okay, so there's a lot to unpack in that question. So let's take it from depression. So if you just want to look at depression, there are many different kinds of depression and many different sources. So that's the function of the history, is to try to pull that apart. So oftentimes what I see, if the person has and this is the most common presentation that I see, is that people have a depression that is low in energy. It's difficult for them to get up and get going. They're sleeping 12, 14, maybe even as much as 20 hours a day, things like that. You want to try and get them going, and you want to look at what are the causes to keep them down like that. So therapy is extremely important. If they have a diamond shape on the scan, we recommend EMDR, which is eye movement desensitization and reprocessing. So for the example of the lady that I talked about, her sexual abuse, she's never been treated for that PTSD. So in her case, she didn't sleep, but you could also have somebody who's sleeping their life away because they've never dealt with that trauma. So the treatment for it is the therapy. And then it depends on the person. Dr. Amen has a great product called Happy Saffron, which I recommend commonly. I get a lot of good results with that. I can use that in combination with medications. And depending on the whole picture, you pick the medication based on the scan. So they often can, I say the Happy Saffron plays well with others. So it doesn't interfere with other medications. It's also safe in pregnancy and nursing. So that addresses the depression part. The hormone part, whenever I see somebody with a chronic depression, one of the first things I look at is cortisol. So in my training, most psychiatrists would also think of thyroid, but in my training, I've been taught to look at the cortisol levels first. And the cortisol is the hormone, of course, made from the adrenal gland, and that's the stress hormone. So if the stress hormone is insufficient, you won't get the conversion of T3 to T4, of T4 rather to T3, which is the active form of the thyroid. So even if you have a low thyroid, you don't want to start treating that thought. You want to treat the cortisol first, and then you can go ahead and treat the thyroid. And so all of that's really important. Depending on if it's a male or a female, you might look at testosterone, you might look at estrogen and progesterone, and all of, you might look at all of those hormones, but I start with the cortisol and the thyroid first.
Thank you for that, Dr. Somner. That's very helpful and informative. Someone had a question as well about the SPECT scans. Would it show something different than a CT scan in the case of someone with chronic migraines?
Well, not necessarily. A CT scan, oftentimes with CT scans, they're normal in migraine, unless you have such severity that you actually have cell death and you see some ischemic evidence of ischemic damage. So no, not necessarily. The SPECT scan doesn't necessarily show that. That's more of a vascular issue.
Okay, thank you. And a question about bipolar disorder. What might we see from the functional brain SPECT imaging view?
So there are a couple of things. I made reference to it when I talked about the thalamus and the limbic system. When you have a white center with red around it, you often get cycling. And so in combination with the history, you can diagnose it. Is this cyclothymia? Is this bipolar disorder? Is it bipolar 1? Is it bipolar 2? It just depends on how it relates to the history. There are times when there's a patchy uptake in the scan in combination with that irregularity in the thalamus, where you'll see it's very, very often a bipolar presentation. So can I hop in here for a second and just talk about Alzheimer's? I noticed somebody wanted to know what the Alzheimer's picture looks like. So
this is great to diagnose the very, very early stages of cognitive impairment and how somebody is moving in the direction of Alzheimer's but hasn't gotten there yet. So what the pattern is, a decrease in blood flow in the temporal lobe and in the parietal lobe, not so much in the frontal lobe. So the example I gave you was a frontal temporal. That's much harder to treat. But the temporal and parietal, where you have significant decrease in both of those, if you have a decrease, you'll have an Alzheimer's pattern of blood flow. So when you have a decrease in both of those, but your memory test is pretty good, it's still in the normal range, but the person is feeling, I can't remember anything. It's so slow to process stuff. My wife is nagging me because I can't finish I can't remember what she told me to pick up at the grocery store. Those kinds of, I can't remember words, those kinds of symptoms, we call that subjective cognitive impairment, where the damage hasn't gone to a place where it's measurable. When it gets to a place where it's measurable, but it's not devastating, we call that mild cognitive impairment. And there's still a decrease in temporal and parietal function. Now, if we can get people in those areas and get them into our memory program, where we look at all of those 11 areas and we can turn all of those things on and people actually do them all, which is a lot to ask of someone, especially when they have some difficulty with thinking. We give them a lot of homework to do, but with the support of family and friends and things, you can usually get them a whole lot better, and you can start reversing that process. You can slow it down. If they're religious about implementing everything in 3 months, that decline, which is progressive and continuous, will stop. So the first thing you see is the reduction of decline. And then if you keep on the program, then you start to see a reversal. So if we can catch you there in that early stage, it works really well.
Thank you. And there's a question as well about overview and respect. Now, I know we've had patients that have come in after a period of time. Maybe they have had an initial comprehensive evaluation for brain SPECT at one of our national 9 locations. And we do have a location that's opening up in South Florida, in the Hollywood area, very soon to follow. But I have a couple of questions that people were asking about that for application in concussion and TBI, and a few other instances. What are your thoughts? Could you describe a little bit more about the ReSPECT scan?
Okay, so there's a lot to unpack in that too. So when you have concussion and TBI, you see oftentimes a lot of damage. Like I said, in talking about the brain scan where there was all that frontal and temporal damage, one of the first thoughts I had is this a catastrophic injury? So you see those areas of the brain are affected by physical trauma. So the treatment for Dr. Amen has a number of things that I kind of put together in a protocol where you use hyperbaric oxygen therapy, you use his supplementation, you use the keto diet, you use certain exercise, you use neurofeedback, the smart mushrooms supplement that he has, those mushrooms have been studied to cause regrowth of the brain. So you put together the entire head injury, brain concussion protocol, and you implement all of those things. And then over a period of time, again, a minimum of 6 months, you can then repeat the scan and you should see improvement in all those areas. Did that address everything, or have I left something out?
I think that was very, very helpful. And also, there seem to be questions coming up around TIA and stroke. Have we had success in treating some of these symptoms? And
well, TIA, like I said, is transient, so it doesn't leave its mark. But if somebody has that history, one of the things you want to focus on is improving their vascularity. Diet, exercise, supplementation, those are all critical for that, so that it doesn't progress into a stroke level. I have seen strokes. There's a very dramatic scan that I have where one half of the brain doesn't light up at all. I call it the half a brain. And it's literally half a brain is functioning and the other half is not from a massive stroke. So the definition of a stroke is that the cerebral accident is sufficient to cause cell death. Now, a complete cell death. Now, there's some wiggle room in there sometimes. When we see a scan on one active in the baseline and then it lights up, it's terrible in baseline, but it gets a little better in concentration. We know we might have a little wiggle room in getting some of that vascular injury to turn back on. But there are times when this stroke is a stroke. I mean, it just kills off the brain and you can't get that back. But what you do instead then is you optimize as much as you can. Like with the Kawasaki case, you just want to optimize as much as you possibly can to improve the function to the extent that the brain is capable.
Thank you. And we have a question about Amen clinics and can we help with long hauler syndrome from COVID?
Oh, that's a hot potato question. I have personally not seen the long haul on the scans. Dr. Amen has a great slides. It has a couple of really great SPEC scans of what happens with COVID in the brain. I've certainly had a number of patients who had the disorder at the time, and it has a major effect on cognition, on mood instability, on anxiety, on moodiness. The only thing my approach would be what I always do is I look at the scan and I see what needs to be improved, and I use all the tools that we have to try and help it along. I personally haven't seen it. I don't know if other docs in the clinic have and what their experience would be with it. I don't have a personal experience to share, but I would imagine that we would be able to get it better. And certainly you have a lot of cognitive issues with it. I've had patients have stroke-like experiences where they couldn't form words. They had temporal lobe injury from the COVID infection. So, and we have vascular components. It's a very complex inflammatory process. Great question.
It is very relevant, very timely. We certainly have had numerous patients who've come in, and also in our New York area and office. We should have a recording to one of the clinical talks that we reported a few months back on some of the findings. We're happy to share that and follow up. For those of you that may want to reach out, feel free to email me. I'll put my contact information in the chat if you'd like to receive more information about that as well. And I also added a note in the chat, if you want to join our professional newsletter to stay in touch about these really valuable clinical programs and talks, we invite you to join our newsletter and share your contact information. And I think we have time maybe for one more question here. Someone had asked about teens with oppositional defiant disorder or conduct disorder. So what can SPECT help us to identify some of the causes? And what are your thoughts around that?
So when we get the conduct disorder, you have a hot anterior cingulate. And very often in the young, where you have that conduct disorder, the prefrontal cortex is on fire in those active scans. So all of those are red and hot. And you have to quiet all of that down. Behavioral therapy is really critical. Working with the parents is really critical. Being able to set good boundaries, but you have to quiet it down too with all the supplementation and with medications and whatever else is going on with the patient. So we have many tools and we can use it. Oftentimes we use them all.
That's great. Thank you so much for sharing some of this rich information and for your time to provide this brain systems overview and some really two fascinating cases. And for those of you that would like to follow up, if you're interested, a few clinicians and professionals had asked about evaluations, going through the Amen method, professional experience, one of my colleagues or myself, we would be honored to follow up and connect. We do have many professionals that come through to see and understand the process themselves. So you can connect with Dr. Somner, or one of our physicians in the team, and see that from end to end and understand and personally benefit for your brain health and optimization of wellness. We look forward to following up with you. And if you have other questions about research, we have a lot of rich resources at the amenclinics.com website. There's a page for our professionals, and we will be sending out the recording and replay to this program. And we look forward to seeing you next time. Everybody take care, and thank you, Dr. Somner.
Thank you.